Hello, today we have lecture day number 5. Obstructive respiratory diseases like asthma, COPD, bronchiectasis, cystic fibrosis. Etiology, pathology, symptoms and signs, diagnosis and treatment. Asthma is a chronic inflammatory disorder of the airways that causes recurrent episodes of wheezing, breathlessness, chest tightness and cough, particularly at night and early in the morning. The hallmarks of the disease are intermittent and reversible airway obstruction, chronic bronchial inflammation with eosinophils, bronchial smooth muscle cell hypertrophy, and hyperreactivity, and increased mucus secretions. Here is a nice picture, narrowing of bronchial orifice. Asthma is one of the most common chronic diseases globally and currently affects 300 million people. The prevalence of asthma has risen in African countries over the past 30 years, but now appears to have stabilized, with 10 to 20% of adults and 15% of children affected by the disease. Asthma is a heterogeneous disease with interplay between genetic and environmental factors. Several risk factors have been implicated. You see here on this slide the risk factors and triggers involved in asthma. Risk factors, endogenous factors are genetic predisposition, atopy, airway hyperresponsiveness, gender, ethnicity. Environmental factors are indoor allergens, outdoor allergens, occupational sensitizers, passive smoking, respiratory infections, obesity, early viral infections. And triggers, about triggers. Triggers are allergens, upper respiratory tract viral infections, exercise and hyperventilation, cold air, sulfur dioxide, drugs, for example, beta blockers, aspirin, also stress and irritants like household sprays, paint, fumes. Etiology, we have atopy, intrinsic asthma, more severe persistent asthma, infections, mycoplasma and chlamydia, genetics, environmental factors like hygiene, diet, air pollution, allergens, occupational exposure. Several other factors have been implicated in the cause of asthma, including lower material age, duration of breathlessness, prematurity, and low birth weight. Asthma is associated with a specific chronic inflammation of the mucosa of the lower airways. The pathology of asthma is remarkably uniform in different types of asthma, including atopic, non-atopic, occupational, aspirin-sensitive, and pediatric asthma. The airway mucosa is infiltrated with activated eosinophils and T lymphocytes, and there is activation of mucosal mast cells. A characteristic finding is thickening of the basement membrane caused by subepithelial collagen deposition. There is also vasodilatation and increased numbers of blood vessels, angiogenesis. The airway may be narrowed, reddened, and edematous. These pathologic changes are found in all airways but do not extend to the lung parenchyma. Small airway inflammations is found particularly in patients with severe asthma. The involvement of airway may be patchy, and this is consistent with bronchographic finding of uneven narrowing of the airways. You see here the lumen of bronchi and is occluded with a mucus plug. Goblet cell metaplasia is present, and the airway wall is thickened with an increase in basement membrane thickness and airway smooth muscle. Inflammation play an important role in pathogenesis. Many inflammatory cells are known to be involved in asthma with no predominant key cell, like mast cells, macrophages, and dendritic cells, eosinophils, neutrophils, T lymphocytes, structural cells. Inflammation in the airways of asthmatic patients leads to airway hypersensitivity and symptoms. Hypersensitiveness and symptoms. The pathophysiology of asthma is complex with participation several interacting inflammatory cells, resulting in acute and chronic inflammatory effects on the airway. Many different mediators have been implicated in asthma, and they may have a variety of effects on the airways that could account for the pathologic features of asthma. You see here inflammatory cells like mast cells, eosinophils, Th2 cells, basophils, neutrophils, platelets. Structural cells are epithelial cells, smooth muscle cells, endothelial cells, fibroblasts, nerves. The mediators are histamine, leukotrienes, prostanoids, PAF, kinins, adenosines, endothelin, nitric oxide, cytokines, chemokines, growth factors. And they do the effects like bronchospasm, plasma exudation, mucus secretion, and AHA structural changes. Inflammatory mediators are cytokines, chemokines, oxidative stress, nitric oxide, transcription factors. Chemokines in asthma, tumor necrosis factor, TNF-A, and other triggers of airway epithelial cells release thymus and activation-regulated chemokine and macrophage-derived chemokine, MDS-CCL22, from epithelial cells, which attract Th2 cells via activation of their CCR4 receptors. This promotes eosinophilic inflammation directly. Airway effects of inflammation is airway epithelial shedding, fibrosis, abnormalities in airway smooth muscle, vascular responses, like increased airway mucosal blood flow, mucus hypersecretion, and neural effects. Airway remodeling. Several changes in the structure of the airway are characteristically found in asthma, and this may lead to irreversible narrowing of the airways. Population studies have shown a greater decline in lung function over time than in normal subjects. However, most patients with asthma preserve normal or near normal lung function throughout life if appropriately treated. Asthma triggers are allergens, virus infections, pharmacologic agents like B-adrenergic blockers, angiotensin-converting enzyme inhibitor, or aspirin. Exercise, physical factors, food, air pollution, occupational factors, hormonal factors, gastroesophageal reflux, and stress. Limitation of airflow is mainly caused by bronchoconstriction, airway edema, vascular congestion, and luminal occlusion with exudate may also contribute. This results in a reduction in forced expiratory volume in first, second, FEV1 forced vital capacity ratio, and peak expiratory flow, PAF. Airway hyperresponsiveness, AHR, is the characteristic physiologic abnormality of asthma and describes the excessive bronchoconstrictor response to multiply inhaled triggers that would have no effect on normal airways. The clinical features and diagnosis. The characteristic symptoms of asthma are wheezing, dyspnea, and coughing. Symptoms may be worse at night, and patients typically awake in the early morning hours. There is increased mucus production in some patients with typically tenacious mucus that is difficult to expectorate. There may be increased ventilation and use of accessory muscle of ventilation. Typical physical signs are inspiratory and to a great extent expiratory, rhonchi throughout the chest, and there may be hyperinflation. There may be no abnormal physical findings when asthma is under control. Now about diagnosis. Lung function tests. This is the first examination. reduced FEV1, FVC ratio, and PAF reversibility is demonstrated by more than 20%, 12%, and 200 milliliter increase in FEV1 15 minutes after an inhaled short-acting beta-2 agonist. The increased airway hyperresponsiveness is normally measured by methacholine or histamine challenge with calculation of the provocative concentration that reduces FEV1 by 20%. Hematologic tests and imaging are not usually helpful. Skin prick tests to common inhalant allergens are positive in allergic asthma and negative in intrinsic asthma, but are not helpful in diagnosis. Differential diagnosis, it's usually not difficult to differentiate asthma from the other conditions that cause wheezing and dyspnea. Upper airway obstruction by a tumor or laryngeal edema, eosinophilic pneumonias, systemic vasculitis, chronic obstructive pulmonary disease or COPD. Aims of asthma therapy: minimal ideal and no chronic symptoms, including minimal exacerbations, no emergency visits, minimal use of as required beta-2 agonists, no limitations on activities, including exertion, dyspnea, PAF circadian variation less than 20%, near normal PAF. Now about treatment. Bronchodilator therapies, beta-2 agonists, anticholinergics, theophylline. Controller therapies are inhaled corticosteroids, systemic corticosteroids, or hydrocortisone or methylprednisolone. Anti-leukotrienes, chromons, steroid-sparing therapies, anti-IgE, omalizumab, and immunotherapy. Effects of beta-adrenergic agonists on airways: relaxation of airway smooth muscle, proximal and distal airways, inhibition of mast cell mediator release, inhibition of plasma exudation and airway edema, increased mucociliary clearance, increased mucus secretion, decreased cough, no effects on chronic inflammation. Now factors affecting clearance of theophylline. Increased clearance, enzyme induction, rifampicin, phenobarbital, ethanol, smoking, tobacco, marijuana, high protein, low carbohydrate diet, barbecued meat, childhood, decreased clearance, enzyme inhibition like cimetidine, erythromycin, ciprofloxacin, allopurinol, zileuton, zafrilokast, congestive heart failure, liver disease, pneumonia, viral infection and vaccination, high carbohydrate diet, old age. Here you see pharmacokinetics of inhaled corticosteroids, GI gastrointestinal MDI metered dose inhaler. Alternative therapies include non-pharmacologic treatments, including hypnosis, acupuncture, chiropractic, breathing control, yoga, and speleotherapy. Future therapies. This has proven very difficult to discover novel pharmaceutical therapies, particularly because current therapy with corticosteroids and beta-2 agonists is so effective in the majority of patients. Management of chronic asthma. Stepwise therapy for patients with mild intermittent asthma, a short-acting beta-2 agonist is all that is required. You see here on this slide stepwise approach to asthma therapy according to severity of asthma and ability to control symptoms. ICS means inhaled corticosteroid, LABA long-acting beta-2 agonist, OCS oral corticosteroid. You see here from mild intermittent till very severe persistent. When we take OCS, LABA, and inhaled corticosteroid high dose. Here you see guidelines for diagnosis and management of asthma. Mild intermittent situation, we have step first, less than 2 weeks, we have days with symptoms, and less than 2 nights with symptoms, 2 months. Days with symptoms less than 2 weeks, and nights with symptoms less than 2 months. No daily medication, and for quick relief of medication, we use short-acting inhaled beta-2 agonists as needed. Oral steroids may be required. And in case of severe persistent asthma, it's step 4. We have continual days with symptoms, frequent nights with symptoms, and daily we take high-dose inhaled steroids and long-acting inhaled beta-2 agonists if needed, add oral steroids. And for quick relief medication, we use short-acting inhaled beta-2 agonists as needed. Oral steroids may be required. Patients with asthma need to understand how to use their medications and the difference between reliever and controller therapies. Education may improve compliance, particularly with ICSS. All patients should be taught how to use their inhalers correctly. In particular, they need to understand how to recognize worsening of asthma and how to step up therapy. Now we consider acute severe asthma. Exacerbations of asthma are feared by patients and may be life-threatening. One of the main aims of controller therapy is to prevent exacerbations. In this respect, ICS and combination inhalers are very effective. The high concentration of oxygen should be given by a face mask to achieve oxygen saturation of above 90%. The mainstay of treatment is high doses of short-acting inhaled beta-2 agonists that are given either by nebulizer or via a metered dose inhaler with a spacer. In severely ill patients with impending respiratory failure, intravenous beta-2 agonists may be given. In patients who are refractory to inhaled therapies, a slow infusion of aminophylline may be effective. Refractory asthma. Asthma is easily controlled in most patients with appropriate medication. The disease is difficult to control in a small proportion of patients, approximately 5% of asthmatics, despite maximal inhaled therapy. Mechanisms of refractory asthma. The most common reason for poor control of asthma is non-compliance with medication, particularly ICS, inhaled corticosteroids. Compliance with ICS is difficult to monitor because there are no useful plasma measurements that can be made. Compliance may be improved by giving the ICS as a combination with the LABA that gives symptom relief. Few patients with asthma show a poor response to corticosteroid therapy and may have various molecular abnormalities that impair the anti-inflammatory action of corticosteroids. Complete resistance to corticosteroids is extremely uncommon and affects fewer than 1 in 1,000 patients. Some patients show aortic variations in lung function despite taking appropriate therapy. Some show a persistent pattern of variability and may require oral corticosteroids or, at times, continuous infusion of beta-2 agonists, type 1 brittle asthma. And others have generally normal or near normal lung function, but perceptions undetectable decreases in lung function that may result in death, type 2 brittle asthma. It's important to check compliance and the correct use of inhalers and to identify and eliminate any underlying triggers. Low levels of theophylline may be helpful in some patients, and theophylline withdrawal has been found to worsen many patients' symptoms. There is some evidence that anti-TNF therapy may be effective, but this is controversial and very expensive. Now, chronic obstructive pulmonary disease, COPD. COPD is a disease state characterized by airflow limitation that is not fully reversible. COPD includes emphysema, an anatomically defined condition characterized by destruction and enlargement of the lung alveoli. Chronic bronchitis, a clinically defined condition with chronic cough and phlegm. Small airways disease, a condition in which small bronchioles are narrow. COPD is present only if chronic airflow obstruction occurs. Chronic bronchitis without chronic airflow obstruction is not included within COPD. Global Initiative for Chronic Obstructive Lung Disease, GOLD, estimates suggest that COPD will increase from the sixth to the third most common cause of death worldwide by 2020. Risk factors of COPD is first, cigarette smoking, airway responsiveness, respiratory infections, ambient air pollution, passive or secondhand smoke exposure. You see here distributions of forced FEV1 values in a general population samples stratified by pack years of smoking. 0 pack years, the first diagram, then 0 to 10 pack years, 21 to 40 pack years, and last is more than 61 pack years. From genetic considerations, we have alpha-1 antitrypsin deficiency. Many variants of the protease inhibitor, PI or SERPINA1, locus that encodes A alpha-1 have been described. The common allele is associated with normal alpha-1 AT levels, antitrypsin levels. The S allele associated with slightly reduced alpha-1 antitrypsin levels, and the zeta allele associated with markedly produced alpha-1 AT levels also occurred with frequencies more than 1% in most white population. The risk of eventual mortality from COPD is closely associated with reduced levels of FEV1. Genetic factors likely contribute to the level of pulmonary function achieved during growth and to the rate of decline in response to smoking and potentially to other environmental factors as well. Here we see a hypothetical tracking curve for force of FEV1. The normal pattern is showed by cure A significantly reduced FEV1, less than 65% of predictive value at age 20 years, can develop from a normal RAT of decline after a reduced pulmonary function growth phase, cure C, you see here. Early initiation of pulmonary function decline after normal growth or accelerated decline after G growth. Pathophysiology. Persistent reduction in forced expiratory flow rates is the most typical finding in COPD. Increases in the residual volume, RV, and the RV TLC ratio, non-uninformed distribution of ventilation and ventilation perfusion mismatching also occur. Airflow limitation, also known as airflow obstruction, is typically determined by spirometry, which involves forced expiratory maneuvers after the subject has inhaled to TLS. Key phenotypes obtained from spirometry included FEV1 and the total volume of air exhaled during the entire spirometric maneuvers. Patients with airflow obstruction related to COPD have a chronically reduced FEV-FVC ratio. Airflow during forced exhalation is the result of the balance between the elastic recoil of the lungs promoting flow and the resistance of the airways limiting flow. In normal lungs, as well as in lungs affected by COPD, maximal expiratory flow diminishes the lungs empty because the lung parenchyma provides progressively less elastic recoil and because the cross-sectional area of the airways falls, increasing the resistance to airflow. In the early stages of COPD, the abnormality in airflow is only evident at lung volumes at or below the functional residual capacity, appearing as a scooped out part of the descending limb of the flow volume curve. In more advanced disease, the entire curve has decreased expiratory flow combined with normal. Lung volumes are also routinely assessed in pulmonary function testing. In COPD, there is often air trapping, increased RV, and increased ratio of RV to TLS, total lung capacity, and progressive hyperinflation, increased total lung capacity late in the disease. Hyperinflation has to compensate for airway obstruction. The partial pressure of O2 usually remains near normal until the FEV1 is decreased to about 50% or predicted, and even much lower FEV can be associated with a normal partial pressure of O2, at least at rest. An elevation of partial pressure of CO2 is not expected until the FEV1 is less than 25% or predicted, and even then may not occur. Pulmonary hypertension severe enough to cause cor pulmonale and right ventricular failure caused by COPD occurs only in individuals who have marked decreases in FEV1, less than 25% or predicted, together with chronic hypoxemia, partial pressure less than 55 millimeter mercury. Cigarette smoke exposure may affect the large airways, small airways, and alveolar space. Emphysema and small airways pathology are both present in most persons with COPD, and their relative contributions to obstruction vary from one person to another. Cigarette smoking often results in mucous gland enlargement and goblet cell hyperplasia. These changes are proportional to cough and mucus production that define chronic bronchitis. But these abnormalities are not related to airflow limitation. Goblet cells not only increase in number, but also in extent through the bronchial tree. Bronchi also undergo squamous metaplasia, which not only predispose to carcinogenesis, but also disrupts mucociliary clearance. Although not as prominent as in asthma, patients may have smooth muscle hypertrophy and bronchial hyperactivity, leading to airflow limitation. Neutrophil influx has been associated with purulent sputum of upper respiratory tract infections that hamper patients with COPD. Independent of its proteolytic activity, neutrophil elastase is among the most potent secretagios identified. A major site of increased resistance in most individuals with COPD is in airways less than 2 millimeters in diameter. Characteristic cellular changes include goblet cell metaplasia and replacement of surfactant secreting Clara cells with mucus secreting and infiltrating mononuclear inflammatory cells. Smooth muscle hypertrophy may also be present. These abnormalities may cause luminal narrowing by excess mucus edema and cellular infiltration. Reduced surfactant may increase surface tension at the air tissue interface, predisposing to airway narrowing or collapse. Fibrosis in the wall may cause airway narrowing directly or, as in asthma, predisposed to hyperreactivity. Respiratory bronchiolitis with mononuclear inflammatory cells collecting in distal airway tissues may cause proteolytic destruction of elastic fibers in the respiratory bronchioles and alveolar ducts, where the fibers are concentrated as rings around alveolar entrances. Emphysema is characterized by destruction of gas-exchanging airspaces. Their walls become perforated and later obliterated with coalescence of small distinct airspaces into abnormal and much larger airspaces. Macrophages accumulated in respiratory bronchioles of essentially all young smokers. Bronchoalveolar lavage fluid from such individuals contains roughly 5 times as many macrophages as lavage from non-smokers. Emphysema is classified into distinct pathologic types, the most important being centriacinar and panacinar. Centriacinar emphysema, the type most frequently associated with cigarette smoking, is characterized by enlarged airspaces found initially in association with respiratory bronchioles. Centriacinar emphysema is most prominent. Panacinar emphysema refers to abnormally large airspaces evenly distributed within and across acinar units. Panacinar emphysema is usually observed in patients with alpha-1 antitrypsin deficiency, which has a prediction for the lower lobes. Chronic exposure to cigarette smoke may lead to inflammatory cell recruitment within the terminal airspace of the lung. These inflammatory cells release elastolytic proteinase, which damage the extracellular matrix of the lungs. Loss of matrix cell attachments leads to apoptosis of structural cells of the lung. Ineffective repair of elastin and perhaps other extracellular matrix components result in airspace enlargement that defines pulmonary emphysema. Upon long-term exposure to cigarette smoke, inflammatory cells are recruited to the lung. They release proteinase in excess of inhibitors, and if repair is abnormal, this leads to airspace destruction and enlargement or emphysema. The elastase and anti-elastase hypothesis proposed in the MID 1960 states that the balance of elastin degrading enzyme and their inhibitors determines the susceptibility of the lung to destruction, resulting in airspace enlargement. However, a complex network of inflammatory cells and additional proteinases that contribute to emphysema have subsequently been identified. Macrophages patrol the lower airspace under normal conditions. Upon exposure to oxidants from cigarette smoke, histone deacetylase 2, deacetylase 2 is inactivating, shifting the balance toward acetylated or loose chromatin, exposing nuclear factor sites and resulting in transcription of matrix, metalloproteinase 9, pro-inflammatory cytokines, interleukin-8, and tumor necrosis factor A. This leads to neutrophil recruitment. CD8 T cells are also recruited in response to cigarette smoke and release interferon-inducible protein T10 that in turn leads to macrophage production of macrophage elastase. MMPs and serine proteinase, most notably neutrophil elastase, work together by degrading the inhibitor of the other, leading to lung destruction. Proteolytic cleavage products of elastin also serve as a macrophage chemokine, fueling the destructive positive feedback loop. Collagen turnover in COPD is complex. The 3 collagenases that initiate the cleavage of interstitial collagens are also induced in both inflammatory cells and structural cells in COPD. Although collagen is disrupted as alveolar units are obliterated, Overall, there is a net increase in collagen content in the COPD lung, with prominent accumulation in the airway submucosa. Airspace enlargement with loss of alveolar units obviously requires disappearance of both extracellular matrix and proteinase degrade lung extracellular matrix as the primary event, with subsequent loss of cell anchoring leads to apoptosis. Animal models have used endothelial and epithelial cell deaths as a means to generate transient airspace enlargement. Whether apoptosis is a primary or secondary event in COPD remains to be determined. The ability of the adult lung to repair damaged alveoli appears limited. Whether the process of septation that is responsible for alveogenesis during lung development can be reinitiated is not clear. In animal models, treatment with all trans-retinoic acid has resulted in some repair. Also, lung resection results in compensatory lung growth in the remaining lungs in animal models. In addition to restoring cellularity after injury, it appears difficult for an adult to completely restore an appropriate extracellular matrix, particularly functional elastic fibers. The most common symptoms in COPD are cough, sputum production, exertional dyspnea. The accompanying worsening airflow obstruction is an increased frequency of exacerbations. Patients may also develop resting hypoxemia and require institution of supplemental oxygen. In the early stage of COPD, patients usually have an entirely normal physical examination. Patients with more severe disease, the physical examination is notable for a prolonged expiratory phase and a expiratory wheezing. Signs of hyperinflation include a barrel chest and enlarged lung volumes with poor diaphragmatic excursion as assessed. Patients with severe airflow obstruction may also exhibit use of acceleratory muscles of respiration sitting in the characteristic tripod position to facilitate the actions of the sternocleidomastoid, scalene, and intercostal muscles. Patients may develop cyanosis, which is visible in the lips and nail beds. Advanced disease may be accompanied by systemic wasting with significant weight loss, wasting, and bitemporal wasting, and diffuse loss of subcutaneous adipose tissue. Some patients with advanced disease have paradoxical inward movement of the rib cage with inspiration, Hoover's sign, the result of alteration of the vector of diaphragmatic contraction of the rib cage as a result of chronic hyperinflation. Signs of overt right heart failure termed cor pulmonale are relatively infrequent since the advent of supplemental oxygen therapy. Clubbing of the digits is not a sign of COPD, and its presence should alert the clinician to initiate an investigation for causes of clubbing. Pulmonary function testing shows airflow obstruction with a reduction in FEV1 and FEV1-FVC ratio. In patients with emphysema, the diffusing capacity may be reduced, reflecting the parenchymal destruction characteristic of the disease. You see here gold criteria for COPD severity from 0 to 4 stage. 0 is at risk, first is mild, 2A moderate, 3 severe, and 4 very severe. The symptoms for 0 stage is chronic cough, sputum production, and spirometry is normal. For first stage of mild severity criteria, we have with or without chronic cough or sputum production. The ratio is less than 0.7 and FEV1 more than 80% predicted. In moderate severity, we have with or without chronic cough or sputum production and ratio, we have less than 0.7 and 50% less of FEV1. More than 50% and less than 80%. Severe stage means with or without chronic cough or sputum production, and it's important that FEV is more than 30% and less than 50%. And in case of very severe cases, we have a ratio also less than 0.7 and FEV1 is less than 30%. Arterial blood gases provide additional information about alveolar ventilation and acid-base status by measuring arterial PCO2 and pH. The change in pH with PCO2 is 0.08 units per 10 millimeter mercury acutely and 0.03 units on 10 millimeter mercury in the chronic stage. Knowledge of the arterial pH therefore allows the classification of ventilatory failure defined as PCO2 more than 45 millimeter mercury into acute or chronic conditions. The arterial blood gas is an important component of the evaluation of patients presenting with symptoms of an exacerbation. Radiographic studies may assist in the classification of the type of COPD. Obvious bulla, paucity or parenchymal markings or hyperlucency suggest the presence of emphysema. Increased lung volumes and flattening of the diaphragm suggest hyperinflation but do not provide information about chronicity of the changes. CT scanning is the current definitive test for establishing the presence or absence of emphysema in living subjects. On this X-ray, you see emphysema with increased lucency, flattened diaphragm, black arrows, increased anterior-posterior diameter, and increased retrosternal clear space, red arrow. You see on this CT scan diffuse bilateral emphysema, CT scan of bullous emphysema. Here you see emphysema destruction of the lungs and mediastinal shift to the left, indicative of hyperinflation. Laboratory findings for subjects with low alpha-1 AT levels, the definitive diagnosis of alpha-1 antitrypsin deficiency requires PI type determination. This is typically performed by isoelectric focusing of serum, which reflects the genotype, antitrypsin, the PI locus for the common alleles, and many of the rare PI alleles as well. Molecular genotyping of DNA can be performed for the common PI alleles. And now about treatment. There is currently suggestive but not definitive evidence that the use of inhaled corticosteroids may alter mortality, but not lung function. All other current therapies are directed at improving symptoms and decreasing the frequency and severity of exacerbations. Smoking cessation, bronchodilators, anticholinergic agents, beta agonists, inhaled glucocorticosteroids, oral glucocorticosteroids, theophylline oxygen, other agents like N-acetylcysteine, intravenous alpha-1 antitrypsin, augmentation therapy. In non-pharmacologic therapies, we see patients, also general medical care, patients with COPD should receive influenza vaccine annually. Polyvalent pneumococcal vaccine is also recommended. Pulmonary rehabilitation, lung volume reduction surgery, lung transplantation. Also, we knew about bronchoscopic lung volume reduction. Treatment of exacerbations, bronchodilators, antibiotics, glucocorticoids, oxygen, mechanical ventilatory support. Now about next disease called bronchiectasis. Bronchiectasis is an abnormal and permanent dilation and destruction of larger bronchi caused by chronic infection and inflammation. It may be either focal, involving airways supplying a limited region of pulmonary parenchyma, or diffuse, involving airways in a more widespread distribution. Common causes are cystic fibrosis, immune defects, and recurrent infections, though some cases seem to be idiopathic. Symptoms are chronic cough and purulent sputum expectoration. Some patients may also have fever and dyspnea. The bronchial dilation of bronchiectasis is associated with destructive and inflammatory changes in the walls of medium-sized airways, often at the level of segmental or subsegmental bronchi. The dilated airways frequently contain pools of thick, purulent material, and the more peripheral airways are often occluded by secretions or obliterated and replaced by fibrous tissue. Three different patterns of bronchiectasis have been described. Cylindrical bronchiectasis. The involved bronchi appear uniformly dilated and abruptly at the point that smaller airways are obstructed by secretions. Varicose bronchiectasis. The affected bronchi have an irregular or bedded pattern of dilation resembling varicose veins. And saccular, cystic bronchiectasis. The bronchi have a balloon appearance at the periphery, ending in lined sacs without recognizable bronchial structures distal to the sacs. Adenovirus and influenza virus are the main viruses that cause bronchiectasis in association with lower respiratory tract involvement. Virulent bacterial infections, especially with potentially necrotizing organisms such as Staphylococcus aureus, Klebsiella, and anaerobes, remain important cause of bronchiectasis when antibiotic treatment of pneumonia is not given or is significantly delayed. Infection with Bordetella pertussis, particularly in childhood. Generalized impairment of pulmonary defense. Mechanism occurs when with immunoglobulin deficiency, primary ciliary disorders, or cystic fibrosis. The primary disorders associated with ciliary dysfunction, termed primary ciliary dyskinesia, are responsible for 5 to 10% of cases of bronchiectasis, primarily ciliary. Non-infectious causes are inflation of a toxic gas such as ammonia or aspiration of acidic gastric contents. An immune response in the airways, bronchiectasis with allergic bronchopulmonary aspergillosis, ABPA, which is caused at least partly by an immune response to Aspergillus organisms. In alpha-1 antitrypsin deficiency, the usual respiratory complications is the early development of panascinar emphysema, but affected individuals may occasionally have bronchiectasis. In the yellow nail syndrome, which is caused by hypoplastic lymphatics, the triad of lymphedema, pleural effusion, and yellow discoloration of the nails is accompanied by bronchiectasis in approximately 40% of patients. Factors predisposing to bronchiectasis are congenital disorders, alpha-1 antitrypsin deficiency, ciliary defect, cystic fibrosis. Infection, bacterial, fungal, mycobacterial, viral. Immunodeficiencies, like primary and secondary. Airway obstructions, example cancer. Connective tissue and systemic disorder. Congenital structural defects. Toxic inhalation, other, example transplantation. Now about clinical manifestations of bronchiectasis. Persistent or recurrent cough and purulent sputum production, repeated purulent respiratory tract infections, hemoptysis. During the physical examinations, we have crackles, rhonchi, wheezing, clubbing, cor pulmonale, and right ventricle failure. History and physical examination, chest X-ray, high-resolution chest CT, pulmonary function test for baseline evaluation and monitoring disease progression, specific tests for suspected causes. All of this helps for diagnostic bronchiectasis. Chest radiograph findings are often non-specific. CT, especially with high-resolution images, provides an excellent view of dilated airways. Appropriate staining and culturing of sputum often provide a guide to antibiotic therapy. When bronchiectasis is focal, fiber optic bronchoscopy may reveal an underlying endobronchial obstruction. Pulmonary function tests may demonstrate airflow obstruction as a consequence of diffuse bronchiectasis or associated chronic obstructive lung disease. Here we see a CT scan of bronchiectasis showing dilated airways in both lower lobes and in the lingula. When seen in cross-section, the dilated airways have a ring-like appearance. Here, chest CT scan in a patient with cystic fibrosis. Severe bronchiectasis is the upper lung, in the upper lung zones with dilated airways and cystic changes. Around show the signet ring sign where a dilated airway is adjacent to a smaller artery. Normally, airways are the same size as or smaller than the adjacent arteries. Here we have diagnostic approach to bronchiectasis. Acid fast bacilli, chest X-ray, chest GERD, gastroesophageal reflux disease, and high-resolution CT scan, pulmonary function testing. Now complications of bronchiectasis. As the disease progresses, chronic inflammation and hypoxemia cause neovascularization of the bronchial arteries. Bronchial artery walls rupture easily, leading to massive hemoptysis. Other vascular complications include pulmonary hypertension due to vasoconstriction, arteritis, and sometimes shunt from bronchial to pulmonary vessels. As ongoing inflammation changes airway anatomy, pathogenic bacteria, sometimes mycobacteria, colonize the airways. Common organisms include Haemophilus influenza, Pseudomonas aeruginosa, Moraxella catarrhalis, Staphylococcus aureus, and Streptococcus pneumoniae. Colonization with multi-drug resistant organisms can lead to chronic low-grade airway inflammation. This inflammation can progress, causing recurrent exacerbations and worsen airflow limitation on pulmonary function tests. Therapy has several major goals. First, treatment of infection, particularly during acute exacerbations. Second, improved clearance of tracheobronchial secretions. Third, reduction of inflammation. And fourth, treatment of an identifiable underlying problem. Prevention of exacerbation with regular vaccination and sometimes suppressive antibiotics. Measures to help clear airway secretions, bronchodilators, and sometimes inhaled corticosteroids if reversible airway obstruction is present. Antibiotics and bronchodilators for acute exacerbations. Sometimes surgical resection for localized disease with intractable symptoms or bleeding. The key treatment goals are to control symptoms and improve quality of life, reduce the frequency of exacerbations, and preserve lung function. Antibiotics are the cornerstone of bronchiectasis management. Choice of an antibiotic should be guided by gram stain and culture of sputum. Infection with Pseudomonas aeruginosa is of particular concern because it appears to be associated with greater rate of deterioration of lung function and worse quality of life. When Pseudomonas is present, oral therapy with a fluoroquinolone or parenteral therapy with an aminoglycosides, carbapenem, or third-generation cephalosporin is appropriate based on antibiotic sensitivity patterns. Mycolytic agents to thin secretions and allow better clearance are controversial. Aerosolized recombinant DNase in patients with CF, cystic fibrosis, bronchodilators, when massive hemoptysis, which does not resolve with conservative therapy, surgical resection, or bronchial arterial embolization. Now about cystic fibrosis. Cystic fibrosis, CF, is a monogenic disorder that presents as a multisystem disease. The first signs and symptoms typically occur in childhood. The median survival is more than 41 years for patients with CF. This disease is characterized by chronic bacterial infection of the airways that ultimately leads to bronchiectasis and bronchiolectasis, exocrine pancreatic insufficiency and intestinal dysfunction, abnormal sweat gland function, and urogenital dysfunction. CF is an autosomal recessive disease resulting from mutations in the gene that encodes the CF transmembrane conductor regulator CFTR protein located on chromosome 7. The mutations in the CFTR gene fall into 4 major classes. Class 1 to 3 mutations are considered severe as indexed by pancreatic insufficiency and high sweat NaCl values. Class 4 mutations can be mild, associated with pancreatic sufficiency and intermediate or normal sweat NaCl values. The prevalence of CF varies with the ethnic origin of a population. Here you see schema describing classes of genetic mutations in CFTR gene and affected of CFTR protein function ratio. The CFTR protein is a single polypeptide chain containing 1,480 amino acids that appears to function both as a cyclic AMP regulated Cl channel and, as its name implies, a regulator of other ion channels. The fully processed form of CFTR is found in the plasma membrane in normal epithelia. The 508 mutations leads to improper progressing and intracellular degradation of the CFTR protein. Absence of CFTR in the plasma membrane is central to the molecular pathophysiology of the 508 mutations and other class 1st to 2nd mutations. Class 3 for 4 mutations produce CFTR proteins that are fully processed but are non-functional, are only partially functional in the plasma membrane. The epithelia affected by CF exhibit different functions in their native state, whereas some are volume absorbing and some are salt bath, not volume absorbing. Others are volume secretory, for example, proximal intestine and pancreas. Given the diversity of native activities, it's not surprising that CF produces organ-specific effects on electrolyte and water transport. However, the unifying concept is that all affected tissues express abnormal ion transfer functions. Organ-specific pathology on lungs. The diagnosed biophysical hallmark of CF airway epithelia is the increased transepithelial electric potential differences. The transepithelial PD reflects both the rate of active ion transport and epithelial resistance to ion flow. CF airway epithelia exhibit abnormalities in both active Na natrium absorption and active Cl secretion. Here you see comparison of ion transport proteins properties of normal A and cystic fibrosis B airway epithelia. Lung, the Cl chlor secretory defect reflects the absence of CAMP-dependent kinase and protein kinase C-regulated chlor minus transport mediated by CFTR itself. There is also a molecularly distinct calcium 2 activated and chlor minus channels, calcium CC, expressed in the apical membrane. This channel can substitute for CFTR with regard to chlor minus secretion and may be a potential therapeutic target. Abnormal regulation of natrium plus absorption is a key feature of CF airway epithelia. This abnormality reflects a second function of CFTR, its function as a tonic inhibitor of the epithelial natrium plus channel. Mucus clearance is the primary innate airway defense mechanism against infection by inhaled bacteria. Normal airways vary the rates of active natrium plus absorption and chlor secretion to adjust the volume of liquid water hydration on airway surface for efficient mucus clearance. The central hypothesis of CF airways pathology is that the faulty regulation of natrium absorption and inability to secrete chlor via CFTR reduce the volume of liquid on airway surfaces. The thickening of mucus and the depletion of the periciliary liquid lead to adhesion of mucus to the airway surface. The predisposition of CF airways to chronic infection by Staphylococcus aureus and Pseudomonas aeruginosa is consistent with failure to clear mucus. Mucus stasis and mucus hypoxia may contribute to the propensity for Pseudomonas to grow in biofilm colonies within mucus plugs adherent to CF airway surfaces. Gastrointestinal tract. The absence of this CFTR chlor channel is the apical membrane of pancreatic ductal epithelia limits the function of an apical membrane chlor HCO3 exchanger to secrete bicarbonate and Na natrium into the duct. The failure to secrete natrium HCO3 and water leads to retention of enzymes in the pancreas and ultimately destruction of virtually all pancreatic tissue. The diminished CFTR-mediated secretion of liquid may be exacerbated by excessive absorption of liquid, reflecting abnormalities of CFTR-mediate regulations of natrium absorption, both mediated by natrium channels and possibly other natrium transformers, example natrium Hellum exchangers. These functions lead to desiccated intraluminal contents and obstruction of both the small and large intestine. Sweat gland. CF patients secrete nearly normal volume of sweat in the sweat acinus. However, CF patients are not able to absorb NaCl form from sweat as it moves throughout the sweat duct because of the inability to absorb chlor across the ductal epithelial cells. This dysfunction in the sweat gland is typically measured by collecting sweat after interferon resin A cholinergic agonist into the forearm. Respiratory tract. Clinical features of respiratory. Upper respiratory tract disease is almost universal in patients with CF. Chronic sinusitis is common in childhood and leads to nasal obstruction and rhinorrhea. In the lower respiratory tract, the first symptom of CF is cough. With time, the cough becomes persistent and produces viscous, purulent, often greenish-colored sputum. Inevitably, periods of clinical stability are interrupted by exacerbations, defined by increased cough, weight loss, low-grade fever, increased sputum volume, and decrements in pulmonary function. Over the course of years, the exacerbations become more frequent and the recovery of lost lung function incomplete, leading to respiratory failure. CF patients exhibit characterized sputum microbiology. Haemophilus influenza and Staphylococcus aureus are often the first organisms recovered from lung secretions in newly diagnosed patients with CF. Pseudomonas aeruginosa, often mucoid and antibiotic resistant, is typically cultured from lower respiratory tract secretions thereafter. Patient-to-patient spread of certain strains of this organism mandates strict infection control in the hospital. Other gram-negative routes recovered from of sputum include alkali genes, xyloxoxidans, and so on and so on. The first lung function abnormalities observed in CF children increased ratios of residual volume to total lung capacity, suggest that small airways disease is the first functional lung abnormality in CF. As the disease progresses, both reversible and irreversible changes in forced vital capacity and forced expiratory volume in first second develop. The reversible component reflects the accumulation of intraluminal secretions of airway reactivity, which occurs in 40 to 60% of patients with CF. The irreversible components reflects chronic destruction of the airway wall and bronchiolitis. The earliest chest X-ray change in CF lungs is hyperinflation, reflecting small airways obstruction. Later signs of luminal mucus infection, bronchial coughing, and finally bronchiectasis. CF pulmonary disease is associated with many intermittent complications. Pneumothorax is common, more than 10% of patients. The production of small amounts of blood in sputum is common in CF patients with advanced pulmonary disease. Massive hemoptysis is life-threatening. With advanced lung disease, digital clubbing appears in virtually all patients with CF. As late events, respiratory failure and cor pulmonale are prominent features of CF. Here you see a chest CT in a patient with cystic fibrosis. Severe bronchiectasis in the upper lung zones with dilated airways and cystic changes. Arrows show the signet ring sign where a dilated airways is adjacent to a smaller artery. Normally, airways are the same size as or smaller than the adjacent arteries. Here we have X-rays of cystic fibrosis with bronchiectasis, apical disease. Gastrointestinal tract. The syndrome of meconium ileus in infants presents with abdominal distension, failures to pass stool, and emesis. The abdominal flat plate can be diagnostic with small intestinal air fluid levels, a granular appearance representing meconium, and a small colon. In children and young adults, a syndrome termed meconium ileus equivalent or distal intestinal obstruction syndrome occurs. The syndrome presents with right lower quadrant pain, loss of appetite, occasionally emesis, and often a paralabal mass. Exocrine pancreatic insufficiency occurs in more than 90% of patients with CF. Insufficient pancreatic enzyme secretions yields the typical pattern of protein and fat malabsorption with frequent, bulky, full-smelling stools. Signs and symptoms of malabsorption of fat-soluble vitamins, including vitamins A and K, are also noted. Pancreatic beta cells are spared early, but its function decreases with age. Genitourinary system. More than 95% of male patients with CF are azoospermic. reflecting obliteration of the vas deferens caused by defective liquid secretion. Some 20% of CF women are infertile because of effects of chronic lungs disease of the menstrual cycle. Thick, tenacious cervical mucus that blocks sperm migration and possibly fallopian tube or uterine wall abnormalities in liquid transport. Most pregnancies produce viable infants, and women with CF are able to breastfeed infants normally. The diagnosis of arrest of the combination of clinical criteria and abnormal CFTR function is demonstrated by sweat test, nasal PD measurements, CFTR mutation analysis. Elevated sweat chlor values are nearly pathognomic for CF. Typically in adults, a chlor concentration of more than 70 mAq on the liter discriminates between patients with CF and those with other lung diseases. DNA analysis of the most common mutations can identify CF mutations in more than 90% of affected patients. The nasal PD measurements can document CFTR dysfunction in the sweat chlor testing is normal or borderline, and 2 CF mutations are not identified. DNA analysis is performed routinely in patients with CF because pancreatic genotype-phenotype relationships have been identified and mutation class-specific treatments are being developed. The major objectives of therapy for CF are to promote clearance of secretions and control infections in the lung, provide adequate nutrition, and prevent intestinal obstruction. Ultimately, therapies that restore the processing of misfolded mutant CFTR or gene therapy may be the treatments of choice. Lung disease: more than 95% of CF patients die of complications resulting from lung infections. The time-honored techniques for clearing pulmonary secretions are breathing exercise, flutter valves, chest percussion. Pharmacological agents for increasing mucus clearance are in use and development. Lung forms of CF, an important adjunct to secretion clearance can be recombinant human DNase, which degrades the concentrated DNA in CF sputum, increases airflow during short-term administration, and increases the time between pulmonary exacerbations. Antibiotics are used for treating lung infections, and their use is guided by sputum culture results. Inhaled aminoglycosides, for example, tobramycin 300 mg breath, for altering monthly intervals are also used twice a day. Inhaled beta-adrenergic agonists can be useful to control airways constriction, but long-term benefit has not been shown. Oral glucocorticosteroid may reduce airways inflammation, but their long-term use is limited by adverse side effects. Atelectasis. Now about a few words about complications which require acute interventions. Atelectasis requires treatment with inhaled hypertonic saline, chest physiotherapy, and antibiotics. For massive hemoptysis, bronchial artery embolization should be performed. Ultimately, the only effective treatment for respiratory failure in CF is lung transplantation. In case of gastrointestinal disease, most more than 90% CF patients require pancreatic enzyme replacement. For treatment of the distal intestinal destruction syndrome, megalodiatrisis or other hypertonic radio contrast material delivered by enema through the terminal ileum are used. Persistent symptoms may indicate a diagnosis of gastrointestinal malignancy, which is increased in incidence in patients with CF. Dehydration caused by heat-induced salt loss from sweat ducts occurs more readily in CF patients CF patients also have an increased incidence of osteoarthropy, renal stones, and osteoporosis, particularly after transplant. And at last, physiological factors. CF imposes a tremendous burden on patients, and depression is common. Health insurance, career options, family planning, and life expectancy became major issues. Thus, assisting patients with the physiological, psychological adjustments required by CF is critical. And we finished. Thank you for your attention.